This week we're going to look at cardiovascular accident and traumatic brain injury. Let's look first at cardiovascular accident, or CVA. This is a stroke. It's the death of brain cells as a result of inadequate blood flow to the brain, and causes include both clots and hemorrhage. The area affected by loss of blood flow will determine what, if any, impact there will be on communication. However, there is no way to exactly pinpoint what or how significant the impact on communication will be. So while we can generally predict what the effect will be, there's no guarantee. And there's no way to exactly tell how severe the impact on the communication will be. And often you don't really know until several weeks after the stroke because of healing. And CVA is the #1 cause of aphasia, and we'll talk a little bit more about aphasia in the next slide. Aphasia literally translates without language. The most common cause of aphasia is stroke, and aphasias are categorized as either fluent or non-fluent, and there are different types of aphasia falling into these categories. In fluent aphasia, the patient is able to easily produce speech and longer utterances. However, what they say may not make any sense. In non-fluent aphasia, speech is labored and it's slow, and utterances may be limited to 1 or 2 words at a time. In addition to the language characteristics discussed in this lecture, neurogenic speech disorder may also be present. These disorders will be discussed in next week's lecture. Let's quickly look at some fluent aphasias. I'm not expecting you to know what every single one of these aphasias are, but if you do any work in a nursing home or in an acute care setting, then these terms may come up and you may want to be familiar with them. And there are different communication characteristics associated with each kind of aphasia. The first fluent aphasia is Wernicke's aphasia. In this kind of aphasia, damage occurs in Wernicke's area of the brain, and this is in the posterior section of the left temporal lobe in most people. In about 4% of the population, the major language areas are in the right side of the brain, but for the 96% of the population, it's in the left side, left hemisphere. People with Wernicke's aphasia are often unaware that they have a problem. They'll string sentences together rapidly, but they don't usually make sense. Speech may be characterized by jargon, and this is the stringing together of non-related words. Comprehension is poor for both reading and listening, and people with Wernicke's aphasia have trouble naming pictures or objects. The next kind of fluent aphasia is anomic aphasia. And in this aphasia, damage seems to be at the point in the brain where the parietal, temporal, and occipital cortex meet in the left hemisphere. And this type of aphasia is characterized primarily by word retrieval difficulties, anomic meaning without name. So they'll have difficulty naming objects and patterns, and there's some difficulty with memory, but their comprehension is not as impaired as Wernicke's aphasia. So they will, in general, understand what you are saying to them. Conduction aphasia is another kind of fluent aphasia. And in this kind, the theory is that damage is deep below the surface of the brain. It's characterized primarily by word substitutions and naming difficulties, and the individuals are aware of their errors, and they will often attempt to self-correct. This is not necessarily the case in Wernicke's aphasia or anomic aphasia, where the awareness is not there. Comprehension or understanding of language in fluent and conduction aphasia is good. And then in transcortical sensory aphasia, everything is significantly impaired except the ability to repeat words, phrases, or sentences. Speech might be lengthy and verbose, but it's going to be filled with errors. And then comprehension is also poor in this kind of aphasia. Let's look at the non-fluent aphasias. Broca's aphasia is the first non-fluent aphasia, and damage occurs in Broca's area. Broca's area is located in the left frontal lobe and is responsible for motor planning and for memory. So individuals with Broca's aphasia usually have relatively good comprehension for listening. They will understand what you're saying to them. They also generally recognize that they have a problem with speaking. but they will have difficulty coming up with words due to that impact on memory. Their speech is slow and labored, and the speech sounds themselves are often impacted as damage occurs in that motor planning area. The second kind of non-fluent aphasia is transcortical motor aphasia, and these individuals have a really hard time initiating speech, but their comprehension is only mildly impacted. So they're going to understand what you're saying to them, and they're generally going to understand that they have a problem. In both Broca's aphasia and transcortical motor aphasia, you're going to notice a lot of frustration as individuals are trying to come up with names of words and trying to come up with a way to convey what they want to say. They're very aware of their issues in general. Individuals with transcortical motor aphasia will have difficulty naming pictures and objects. And then finally, in global aphasia, all areas of language will be affected. Expressive language will be very limited. Patients may repeat one word or phrase over and over again. Often it's something that carries a high emotional content to it, so they might be profane words. Comprehension is extremely impaired, and they'll have the inability to point to pictures, and they won't be able to follow any directions except for really simple, basic routine directions. These videos, and hopefully they'll play a little better, are just a couple examples of Wernicke's aphasia versus Broca's aphasia. So you'll see Wernicke's aphasia, remember, is the fluent aphasia. So she can produce those utterances, but she doesn't necessarily understand everything that's being said to her. And she doesn't necessarily make sense herself.
Thanks. Okay. Caterpillar, cantaloupe.
She has trouble repeating back what's said to her.
All right, I'd like for you to do some things now with your mouth. First thing I'd like for you to do is stick out your tongue.
Stick your tongue.
Great. Show me how you would kiss.
Show me how you love to kiss me.
There you
That's
go.
good.
Show me how you sip. There you
That's
go.
good.
Show me how you sip on a straw.
She does not understand this at all.
Okay. Can you sip on a straw?
See what a sip sticks. See what a sip sticks onto me.
Okay. Try this one.
She's trying to say something, but she can't get the words.
Listen.
It's kind of nonsense.
Show me how you smile.
Show you how plus me. Show how plus me. Show how plus me. Show how plus me.
Stop. Can you smile?
Can you smile at me?
No,
Can you smile at me?
Don't say what I say. I want you to do this. Watch.
What? Look at me.
Smile. There you go. That wasn't a very good one, huh? Smile.
Smile.
There you go. Chew. Show me how you chew gum.
Chew what you so my children think.
Okay, watch this. Good.
So she's talking, but she's using nonsense words. You can see that her understanding is limited. She really doesn't know what the person administering this test is asking her to do. She's trying to repeat back the words, which is what she was doing in the first part of the test, rather than follow the directions. This next video, if we get there, is an example of Broca's aphasia.
Now tell me what this thing was with your legs last week or week before.
No good.
It's taking him a long time to come up with the word ache.
And
You can see his frustration will increase,
uh,
but he understood the question. But notice how patient his communication partner is being and giving him time to process and to think.
knees and
It's his knees
ankles.
and his ankles.
Uh,
And then notice the listener's body language as well. He's leaned into him, which encourages him to
What'd you
keep
do about it?
trying. He's going to ask some questions to help.
home, doctor, and legs. Uh, walking, no good.
No good, huh? Man, you're a fellow who likes to walk, too.
Oh,
Yeah?
jeez.
Huh?
Oh, boy, oh, boy.
So he uses
And it's
what he
getting
knows
too
about him.
cold
Yeah,
to run your John Deere tractor, isn't it?
Yeah,
Up and
yeah.
downtown.
yeah.
What'd the doctor tell you, Jack?
Don't know.
He doesn't know what's going on,
No.
huh?
No.
So he's interpreting back to him.
Did you feel
Not
sick
that the
in any
man
other
didn't
way?
know what the
No.
doctor said,
No,
but that
no.
the doctor doesn't know what's going on.
Ache.
Yeah. Legs ached.
Yeah.
So you can see the strategies that he's using there are really nice. His body language is encouraging communication. He's giving his client ample time to respond, and then he's interpreting the responses to make sure that he understood exactly what his client was trying to convey. Right hemisphere damage is another kind of brain damage that will impact communication. In 96% of the population, the left hemisphere is the dominant hemisphere for language, and it's where most of the understanding and production of speech and language take place. However, the right hemisphere seems to play a larger role in things like understanding humor, interpreting metaphors, understanding tone of voice, so different emotions, emotional interpretation, sarcasm, and also in interpreting body language. So individuals with damage to the right hemisphere are going to demonstrate difficulty with these kinds of tasks. And then traumatic brain injury. And traumatic brain injury is most common in very young children as a result of falls, and then again in young adults as a result of accidents such as automobile accidents. And traumatic brain injury is damage to structure or function of the brain as a result of a blow or jolt to the head or of a penetrating head injury. I worked with a client whose husband hit her on the head with an axe, and that penetrated the skull, um, and it caused brain damage. So it's not just a closed head injury, but also penetrating head injury. Some common symptoms of traumatic brain injury. And these will vary depending on how close in time you are to the injury. Um, some of these symptoms, as time progresses, will get better, and some of them will improve and then plateau. You're going to see confusion, and this is especially true in the early stages of recovery. Patients may not know what happened to them. They may have no memory of what happened to them, and they may not understand their limitations and what has caused those limitations. You want to make sure that you're orienting your patient to where they are, um, what day it is, in terms of date, just so they have an idea of that. And as a result of the confusion and not really understanding what happened, and as a result of frontal lobe damage, you're going to see some mood swings. Patients can become very easily agitated. They have a low frustration level, and they can go from being calm to violently angry very quickly. So you want to be monitoring that. Also, there will be disinhibition. So your client may say or do things that are socially inappropriate. This is kind of similar. Certain drugs can cause disinhibition, and brain injury will too. Um, they may not realize that these things are socially inappropriate, and they may need frequent reminders of what they can and cannot say. And the way to treat that is really just to say, you know what? This is not the time or place to talk about that. It's really not an appropriate topic of conversation, and then just move on. You want to be really matter of fact. You don't want to cause people any embarrassment because, like I said, they may have no awareness of what it is they're saying or doing is not appropriate. And then they're going to have language difficulties. There'll be trouble coming up with words. Um, they may make comments that are irrelevant to the conversation. And then when retelling stories, the events that they tell may be out of order or they may not follow any logical sequence at all. So they may tell you about something that happened to them during the day, and the steps might be all out of order. Some communication strategies. In cases of stroke, right hemisphere damage, and traumatic brain injury, it's especially important to remember that patients, they're going to be experiencing a sense of loss and a wide range of emotions, and they're often going to be working through the grief process. Unlike the other disabilities we've discussed to this point, people are losing skills that they already had. So they're going to be working really hard to get back skills that they already had, and already in a lot of cases already used really effectively, were really effectively able to communicate. Um, and that causes people a lot of frustration, and understandably so. So we want to keep that in mind. The other thing we might want to that we need to keep in mind is that these patients may also be experiencing physical pain. So some important strategies that we can use in these patients are we want to make sure you're treating your patient or client in an age-appropriate manner. Most stroke patients are adults. Many traumatic brain injury patients are older teenagers or younger adults. And it's important to address your patients as such and to treat them as you would treat an adult. Um, Even though understanding may be impaired, even though they may not communicate with you like other adults communicate, you still need to treat them in an age-appropriate manner. Um, you want to communicate with them on the level that they're communicating, but you don't want to communicate with them like you would communicate with a child. So you want to make sure that you're not calling them things like cute or raising your voice so that it's high pitched like you would talk to a little kid. Oh, hi, something like that. You want to make sure you're talking to them as you would another adult. You could use Mr. or Mrs. and then their last name and all those signs of respect. The other thing that you want to do is allow adequate time. In the video with Broca's aphasia, some of those pauses seemed really, really awkwardly long. But that man was actually communicating very effectively with that person with Broca's aphasia. Um, you want to try not to interrupt. You want to wait until your patient or client is done speaking. And if you need to, repeat back to them what they've said or how you've interpreted what they've said to see if you've understood. So when the man asked what the doctor said and the person with aphasia responded, don't know, the man interpreted that as the doctor doesn't know what's going on. And then the man with aphasia confirmed that. Um, you want to be patient and calm. Communicating is going to be frustrating both for the patient and it's going to be frustrating for you. But when you allow adequate time, you're communicating that what your communication partner is trying to say matters to you. And you don't want to convey that frustration. Use that good body language that you're really trying to encourage what your client's trying to say. Sometimes just listening is one of the best things you can do in earning your client's trust and in establishing a good rapport so that you're able to help them. So allow that adequate time and show that you're being a good listener. You also want to keep your language clear and simple. Make your directions or make sure your comments or directions are short and to the point. And when you're asking questions, make sure you're not asking for too much information at one time. Just ask one question at a time and make sure that the person is able to provide that answer. Use visual cues. Visual schedules and things like calendars and organizers are going to be helpful in keeping your client on task and oriented. They can also help improving understanding and processing information. The visual information does not disappear like verbal information does. These cues aid in comprehension. Let your client know when something is not an appropriate topic. This is a big one. TBI, people with traumatic brain injury, and clients with right hemisphere damage especially can either be off topic or just plain inappropriate. Don't be afraid to politely but firmly let them know that what they've said is not appropriate or acceptable. And then you want to refocus them back on task. If they're just off topic, just say, oh, that's not what we're talking about right now. We can talk about that later, and then bring them back to the topic. Often people outside of the therapy setting might not be willing to tell people when something is not an appropriate thing to talk about. So you shouldn't be afraid to politely let them know that what they're saying is not okay. Model what you're asking for. If there's something you're trying to get your client to do, you may need to model the task. Show them what you want them to do. Repeat the directions if necessary, multiple times if you need to. And then technology. Your client may come to you with an alternative way of communicating. Once again, ask whoever programs their device to create a page or folder specifically for your needs or to teach you how to do this. Proximity. Stand within a few feet of your communication partner, just like before, and then make sure you're face to face and on the same level. If your client's in a wheelchair, then you can sit or you can crouch down. If they're standing, you're working with them standing, then you can be standing too. If they're laying down in their bed, then you can pull a chair up next to the bed. But try and be on the same level. Once again, this conveys respect, and it gives them a clearer view of your face. Try to work in a place that's free of distraction. Individuals with stroke and with TBI can become easily distracted by what's around them, and they already have trouble staying on topic. So you want to try and work in a place that's distraction-free. And that concludes our discussion on cardiovascular accident and traumatic brain injury.